Welcome back, everybody, to our last physics lecture. You did it! We're here, we're done. This lecture is going to cover mostly just some random things that I've noticed along the way that show up in some mock tests that I've looked at, show up in some other textbooks that the A11 textbook doesn't really cover. And the last thing I want is for you to go into your physics test, realize maybe we didn't cover a couple topics, and then fail by just one or two questions. Granted, I don't want you to be that close at all, but I would feel really awful if it was that close and we didn't have this kind of random information at the end here, just to make sure that we at least introduce all the ideas possible that I can about the SPI. So that being said, we'll just go over these kind of random topics. There is not going to be a student quiz for you to create. There will not be an instructor quiz for you to take. You will need to do your workbook, and you will need to submit a hint or a tip on how to remember one of the concepts from this lecture. Some of this might feel a little redundant to chapter 23, I believe. These are just a couple things I just wanted to highlight again, since I did not formally lecture on that chapter. The first one being, though, that patient identification. We need to identify our patient. There is nothing worse than realizing after you've completed your study that you did it on the wrong patient. And it hasn't happened to me, knocking on wood, but I've seen it happen to coworkers. And the problem with ultrasound images is that all that information up on the top, the patient name, their date of birth, MRN, that's all burned into our picture. When you freeze a picture on your ultrasound machine, everything on your display is frozen into that picture. And so, say you did John Smith's ultrasound under John Jones's name, all of John Smith's pictures are going to have John Jones's name on it, and you can't get rid of that. It's not as easy as just going into PACS or going into your ultrasound system and be like, oh, change that name. It doesn't work that way. So always make sure you're identifying your patient. One of the things I like to do when I go into the room, the very first thing I say to the patient, hi, my name is Molly, I'll be doing your ultrasound today. Can you tell me your last name? Can you tell me your date of birth? Those are the first two verbal things that I check with them. If they have a wristband on, they don't always at the outpatient clinic that I work at, but they always have them as an inpatient. I then double check their wristband. It matches what they told me. I then also double check, what do I have pulled up on my machine? Do I have the right person? Do I have the right date of birth? Does the MRN match? Now the MRN is short for medical record number. Everybody gets assigned one in a medical system. It is used kind of as more of an anonymous identifier for the patient. Most patients won't know their MRN. So yes, it's an identifier for us to visually check, but it is not a verbal thing. You wouldn't ask your patient, what's your MRN? They're not gonna have an idea. So date of birth and full name are going to be your standard verbal identifiers, and then you want to make sure that you're checking your MRN name and date of birth against your order and what you have up on your machine. HIPAA is another really key topic to medical services. HIPAA was a law that was put out quite a few years ago. I don't remember the date off the top of my head, in the 90s. And basically the whole point of it was that we needed to figure out how to standardize how records are released. So now we have all these forms that people have to fill out, and they have to grant permission for their electronic medical records to be sent somewhere else. And then they can limit, how long can a facility do that? They can limit where does my information go to? So there's a very standardized process in releasing those records. It's also to protect health records. We don't want people's information just being out there. This is protected personal information, PPI. You'll hear that term once in a while. And that PPI is both in-house. When you have your ultrasound machine up, oftentimes it's going to have multiple studies on there, multiple names, multiple dates of birth. You don't want your other patients seeing that, so it's important for you to churn the screen. When you're logged into the medical system, make sure you log off before you leave that computer. Somebody could just walk up to it and start accessing the medical records. So you need to protect health records when you are in proximity to them, when you're using them. It also set ground rules for how to apply penalties and violations. It costs a lot of money if you are found guilty of violating HIPAA, even if you don't mean to. There are quite often times, you'll hear these stories when you start working out in the field. You'll have like hospital orientation, and they'll talk endlessly about accessing medical records that you have no business of being in. So you're in the EMR, you have the right to go look at your own patient's stuff. You're providing direct care for that patient. You can't go look at your neighbor's stuff. You can't go look at your friend's stuff. You can't go look at the celebrity that's in the hospital. You can't look in their medical records unless you are providing direct patient care for them. If you do, and you have no reason to be in there, I think it is $10,000 for doing that, just looking, even if it was an accident, $10,000, and you will most likely lose your job. When I was working at Children's Hospital, we actually had a really high profile patient, and we were all warned, don't go into that chart unless you need to be in it. And that makes sense. Like, you shouldn't be in any charts that you don't need to be in. But on top of that, there was somebody who wasn't even at the hospital who looked up this patient's information, just looked at the images in PACS, because they were curious, how did the trauma images, what did they do? What was the protocol for that? So they were just curious how they ran those images in X-ray, and had mentioned it to a supervisor, just thought she was completely in the right. She wasn't. She got fired because they looked into another patient's records that they had no right to be into. So very important that we are using medical records as they are intended. And then lastly, it's also to provide more patient education. Patients receive documentation as to why and how and when and who can access their medical records, and it's just the goal is to make people feel more comfortable, feel more educated about the process of medical record sharing. Going along with some more patient communication, it is important that we consider our knowledge. I mean, we've been in school, you're going to be in school for 2 years learning all this medical jargon and technical terms, and you need to be able to take that information and then relate that to a patient. Not everybody speaks medical. In fact, they have found that most people don't understand what their doctors are talking about when they go to a doctor visit. And they have found that you need to bring it down almost to like a 5th grade level to really clear up what you're talking about. So if a patient is asking you, is this safe for my baby? Well, you can't be like, well, we use Lara and we have the thermal index and mechanical index and blah, 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 blah. You can't go into that stuff. You need to be able to bring it back and be like, yes, there are no studies that prove that there's any damage to babies. Yes, we'd want to say there aren't any bioeffects to the fetus. Even that is medical terms. That's jargon. And yes, most people will be able to follow it, but there's a lot of people that won't be able to follow it as well. So make sure that you understand ultrasound physics. Make sure that you understand diagnostic medical sonography, so you can then relate that information to the patients as they ask. It's also important to remember that communication does happen in both verbal and nonverbal ways. So a big part of our job is, taking those pictures, getting all the information that we need, and we can't react to what we're seeing. You can't start crying, you can't gasp if you see this giant mass in the heart or in the abdomen. You need to compose, take the images, move on. And that's a big part of that verbal, nonverbal communication. Also just being clearly at ease, open to the patient, friendly to the patient in those nonverbal ways helps to alleviate some anxieties that your patient might have as well. So being a good communicator as a sonographer is also very important. Lastly, use an interpreter when necessary. Anytime that I have a patient that does not clearly understand what I am talking about, I'd like to get the medical interpreter involved, be it through on the phone an in-person one, or they have video, kind of rolly video carts that you can do interpreters through now too. It just covers you, especially if I'm doing like a transvaginal ultrasound where I'll be inserting a probe into the vagina. If you're doing a procedure on somebody, you have to have an interpreter. They need to consent. They need to have all the information to consent to the procedure that you're about to do. So when in doubt, grab an interpreter. It's easier to cover yourself that way than to get in trouble on the backside of it. The other part too is family members are very helpful with interpreting, and I use them quite often if everybody's comfortable with it. But if there's anything that might be considered, I guess, bad news, then I'm going to want to use a medical interpreter. What they have found is that family members might censor what they tell the patient, or they might not understand what the doctor is saying or what you're saying, and then misinterpret that for the patient. So if you're telling the patient, we found a tumor, we're afraid that it's cancer, we need to do XYZ for this, then the patient's family member might say, oh, everything's fine, don't worry, mom. And that's just really not the whole point of having the interpreter there. So we want to make sure that we are giving our patients the best care, and sometimes that does mean getting a professional medical interpreter and not using family. Along with communicating with the patient, it is important that we communicate some of our questions to the patient as well. So we want to make sure that we are asking the patient appropriate history questions, so we can then take that information and relay it to the radiologist or the cardiologist, so they know some background information and kind of can work the differentials in different ways with what we find in our imaging. Now, quite often you're going to have, again, access to that EMR, that electronic medical record. You'll be able to see what labs they've had, what medicines they're on, what previous imaging they've had. That's all stuff that you should be looking up as a sonographer. But quite often you'll get orders for a patient that you've never seen before, they've never been in your system, maybe they moved from out of state, you just don't have that background information. So you want to make sure that you're asking appropriate questions for your patient in relation to your exam. There will be times that you're faced with emergency situations. It's important too for the sonographer to be prepared for emergency situations. One of the biggest ones is when a person goes into cardiac arrest. So we start to perform CPR, cardiopulmonary resuscitation. You will be responsible for being certified in CPR before you leave school. Once you get certified, you are certified for 2 years, and then just need to do a renewal course with the American Heart Association or a BLS type course. In general though, if a person becomes unresponsive, and we're going to use the hospital as an example, you want to make sure to try to arouse that person, try to shake them, see if they're okay. If there is no response, you're going to call a code. Codes in hospitals are usually code blue for some sort of heart attack or cardiac arrest. There's also rapid response if maybe somebody fell and hit their head but they're still breathing. You just need a team there right away. So there's different colors, different types of codes that you can call. You'll be familiarized with these once you start working or once you start clinicals. But always be prepared to start CPR on a patient who does not have a pulse, or be prepared to go get a defibrillator or to help somebody that is going through the CPR protocol. Another thing that we see as emergency situations is diabetics are quite often asked to fast for exams, especially for our abdomen exams. And when blood sugar gets out of whack, it can cause a lot of problems for the patient, so they can go into shock. And so we just want to make sure that when we have a patient who is diabetic and maybe hasn't eaten, we're going to take our time helping them, making sure that they get a snack, making sure that they're safe in our care. If we have an elderly patient that needs a walker, we're not just going to walk away from them while they're standing or going to the bathroom by themselves. We want to make sure that we're always with our patient and watching out for their care while they're with us. Also working in probably more the hospital situation, you'll come across some of this in the outpatient scenario as well, but really focusing on the hospital part of it, infection control and precautions are super important that we are aware of them. We are aware of the risks that they hold for us and how we play a role in the prevention of spreading diseases in the hospital. So some of the big viral or bacterial exposures that we are exposed to working as healthcare workers are hepatitis B and C, HIV, tuberculosis, MRSA, and C. diff. Now, hepatitis B does have a vaccination for it. You'll be required to have that before you leave for clinicals. If you have not started that already, I do suggest that you just get it now. It takes quite a while to get it because you have to have like 3 months in between each set of vaccinations. Most people have probably had it though when they were born. It's now part of the newborn vaccination series. So most of you have probably already had it. It's also a good idea to just double check your records, make sure you're set to go for clinicals instead of finding out right before clinicals that you have to get all these vaccinations and more work done. HIV leads to the disease AIDS. We know that it's spread through bodily fluids, typically through dirty needles or through sexual contact. Any of these that are spread by bodily fluids, what most likely is your biggest risk as a healthcare provider is some sort of accidental needle poke. Maybe we're doing a procedure on a patient and the needle somehow nicks you. That is a potential space for transmission. So this is more where your risk comes in. You want to make sure you know your facility's protocol for those accidental needle pokes. I've had it happen to me once. The patient had to get tested for AIDS and I had to get tested, or for HIV, and I had to get tested for HIV. Both of us were negative. But in the event that you actually know you have a positive Hep B, Hep C, HIV patient, they have medications that they'd start you on right away. Tuberculosis is an airborne disease, usually spread by people coughing or sneezing. So any of these like droplets that can come out of the mouth from a tuberculosis patient can easily infect those around them. Suspected TB patients are going to be in negative pressure rooms. So that means that their droplets, their airborne materials, are actually going to get sucked out of the room pretty quick instead of being able to kind of mingle and linger in a room. So you'll hear that term, negative pressure. There's usually a negative pressure room in the radiology department because these TB patients need to have chest x-rays. And there's usually negative pressure rooms in the ER when a patient is exhibiting respiratory symptoms, then they'll want to put them into that negative pressure room. Tuberculosis is also tested prior to beginning work in the healthcare field and typically yearly afterwards. They do a Manto test, which is this little injection underneath your skin. If you have a reaction to it, then you are positive for tuberculosis. They also have blood tests that they can do to test for this as well. MRSA then is a superbug, is what they call it. It is a bacteria that is resistant to antibiotics. So we have used antibiotics for so long and for so many pathogens that the bacteria morph and then they get stronger when they morph, and now they're no longer reactive to the antibiotics that we have. And that's exactly what MRSA has done. So they call it the superbug because you can't attack it with antibiotics unless there might be some really, really strong ones that can get to it, but they aren't super effective. So MRSA is a very easily spread disease through the hospital. It is just spread by coming in contact with somebody with it. So as a hospital care worker, you want to make sure that you are following contact precautions, gowning up, degowning appropriately, washing your hands, not being part of the infection chain when you are moving through the hospital and into different patient rooms. The last one then is C. diff. C. diff, what typically happens, a patient is on antibiotics. The antibiotics wipe out all the good bacteria in their bowel. And what is left is this Clostridium difficile. And this kind of overtakes the bowel. It causes colitis. It causes diarrhea. And these C. diff particles are like these little spores. And so most people use the foam in, foam out. That's an alcohol-based cleaner. Well, when these spores come in contact with the alcohol, they put this, I think it's called like an echo spore, or I don't know, it's like this hard shell around the spore, and it does nothing for it. And so when the alcohol is gone, the spore is active again, and it can infect people. So C. diff can only be controlled by using bleach wipes. So we have bleach wipes in the hospital to help with C. diff. We have alcohol-based wipes for other things that typically will kill most viruses. So again, there's just all these little things that have popped up over the years that as a healthcare worker you need to be aware of, and how do we deal with it. So one of the ways that we deal with it is labeling the patients that are in isolation and why they're in isolation. So these are patients that have known MRSA, patients that have known C. diff, have known TB, maybe have pneumonia, maybe they have cancer and are immunocompromised. So they're in isolation, and typically in the isolation rooms we have images that help us to remember what we need to do when we are in contact with that patient. So in a patient that has MRSA, they'd be under contact precautions. Outside of the room would be gloves, gowns, foam, anything that you would need to go into that room. So you gown up before you go into the room, perform your procedure, then you take everything off before you leave the room so all the contaminated material stays in that patient's room. And then upon discharge of that patient, that room gets a really thorough cleaning before anybody else gets put in there. So always make sure that you're reading your patient doors before you're going in. Most people just be under the standard precautions. Standard precautions include washing your hands, using gloves when appropriate, washing your hands after touching the patient, and making sure to wipe down surfaces. This last picture here that's on this slide, this is just kind of a more detailed look at some of those precautions. What should we be doing in the event that we come into a contact precaution room or a droplet precaution room, and some of the examples of diseases that go along with it. As I mentioned earlier, it's a really important part, one of our important roles is that we don't add to the infection chain, that we are not part of it. So we're going to make sure that we're always washing our hands, that we're using gloves, that we are cleaning the machine, cleaning the probes in between patients, so we are not spreading MRSA or C. diff around the hospital. When a disease is spread through a hospital, it's called a nosocomial infection. And nosocomial infections can be a very big deal in the hospital. They can spread very quickly once they start. So nosocomial infections are infections that are hospital acquired, like MRSA or C. diff. Another really common one is urinary tract infections. Patients are fitted with a Foley catheter. That's a urine bag, a catheter that drains the bladder. And if that catheter bag is placed above the patient's bladder, the urine cannot come out. It's gravity dependent. So when you're transporting a patient with a Foley catheter or a urine bag, you always want to make sure that it is below the level of their bladder. What they have found is the inappropriate placement of that urine bag can cause urine to back up into the bladder, therefore causing a urinary tract infection. So urinary tract infections in the presence of a catheter is another example of a nosocomial infection. Continuing on with our kind of randomly seeming stuff, sterile technique. As a sonographer, you will most likely at some point in your career be involved with some sort of procedure. And you need to be aware of what sterile technique, what sterile asepsis is in regards to your job. So as a sonographer, I have been involved in cases in the surgery suite. When we are in surgery, you're making sure to wear a mask, you're wearing booties over your shoes, you're wearing surgical scrubs, ones that have not been out of the hospital. You have to wear a hair bonnet. When you come in, you have to wear gloves on both hands, and you'll see like a large table that is considered sterile. You don't want to get anywhere near that table. The patient is sterile once they're clean, especially if they're doing abdominal work, or if they're cutting into the chest, or if they're cutting into the brain. All that area is going to be prepped and considered sterile. So you need to bring in a clean machine. So you want to make sure you're wiping down your whole machine. You're going to bring in a clean probe. You want to make sure it's nice and clean. Use a probe cover to stay even more sterile. And they're going to help direct you on where they want you so you can help them with your imaging. In general though, the sterile field is where all the tools and equipment are going to be. They're going to be the physician's hands and the front part of their gown. You'll notice when people move past each other in the OR, that they move back to back. Backs are not considered sterile, the front part is. So they cross each other by going back to back. Some good rules to follow when you are near a sterile field: just be aware of where the sterile field is and what is sterile on it. So another example of sterile procedures that you'll be doing as a sonographer, you might be helping out with a cardiocentesis or a paracentesis or a thoracentesis where you're drawing fluid off the body. When we're entering a needle into this patient's body, we want to do it under clean, sterile conditions when we can. If we're doing a breast biopsy, anything that introduces needles, you want to be in more of that sterile field or sterile environment. And so when we open up trays, because that's part of our job, is getting the trays ready, we're going to be very careful to keep the environment sterile. We're going to open things from the edges, touching as little as possible, making sure that we've washed our hands, using gloves, doing whatever we need to do to not introduce more pathogens into the area. Even though it's important, once you have a sterile field set up, don't leave it alone. A lot of people are tempted to set everything up and then walk away from it. You really do need to stay with that sterile field to ensure that it is stayed in the sterile position and that nobody came in and touched or licked a bunch of things. Lastly, two last thoughts that I have on it too: never reach across the sterile field. If the doctor wants you to hand something to them, don't reach across, reach around it, move around it if you can. If you touch anything on that sterile field, it needs to be removed immediately. Another thing too, if you think anything is unsterile or contaminated on that field, get rid of it and let people know. If you drop something on the ground, don't just kind of look the other way, pick it up and put it back. No, that's not okay. You gotta get rid of it, get a new set of gloves out, get a new needle out, replace the part that has become contaminated. Another topic that we didn't talk about during the transducer lecture, which I think it probably would have fit in well there, but we're going to do it now, again, mishmash of everything, is endocavity imaging. So endocavity means inside the body. So we are using a probe inside an orifice of the body. We have 3 endocavity type probes that we use quite often in ultrasound. The first one here is a transesophageal transducer. We can see here we have this cord. This part attaches back to the machine, so it creates ultrasound pictures just like we're used to. This little knob here is for steering. And then you have the esophageal part. This is inserted into the esophagus and lowered to the level that we need. So if it is being used for transesophageal echoes or TEEs, they're going to lower it down to the level of the heart, mid-chest, and you kind of get to see the heart from behind instead of going through the lungs. So it actually provides a really nice view of the heart. For general applications, they can use this. They can insert that probe a little bit further and look at the pancreas through the esophagus. Actually gives a really nice view of that, where typically we can't see it because of stomach or bowel gas. So the TE is inserted into the esophagus. There are PCT crystals right at the very end of it here, and these crystals can be steered in any direction to see a 360-degree view of the anatomy at that level. Another type of endocavity transducer that we have is the transvaginal transducer. It usually is a slim transducer, a little bit more bulbous on the end, and then it has a long handle coming out of it. This is going to be inserted into the vagina. It is used to evaluate female pelvic organs in much more detail. What I want to point out about the end of the transvaginal transducer is that this is our footprint here, and it is a very curved footprint. It's also going to have curved elements on it. So you can see in our picture here, we're following kind of what looks like a convex probe, but these are considered microconvex because this is a really tight curve. But because of that, then we have kind of a small footprint and then a very large field of view, which is awesome for what we're doing. Last type of endocavity imaging then is the transrectal transducer. This is, again, another slimmer profiled transducer, usually not as bulbous on the end as the transvaginal ones are, and the handle is quite a bit shorter because it is only being inserted a short ways into the rectum. The rectal transducers are typically used to aid in the evaluation of the prostate and for biopsy. So again, we can see kind of that bite out of the sector field. We've got that curve here with the curved elements going around. So our endocavity transducers do have curved elements. Sometimes they're referred to as microconvex probes. Again, just because of how tight that curve is up at the end of the probe and the view that we get from it. The special consideration for endocavity imaging is that those transducers have to be cleaned in a different way than our on-the-body transducers, our normal transducers that we're using. And that's because they come in contact with mucosal surfaces. Any mucosal surface is a risk for transmitting disease, and then because these are hard plastic with crevices in them, we would be concerned that we then have transmitted that disease onto our transducer, and if we don't clean it appropriately, we could spread that to another patient. Most endocavity transducers are going to be covered with some sort of probe cover, so that's going to eliminate some of the direct contact, or most of the direct contact that transducer has with those mucosal surfaces, but just to ensure proper cleaning, we are then going to either send it to the biohazard place. Oh, I can't think of the name of it off the top of my head. Usually the TEE, the transesophageal ones, they get sent to a special place to be disinfected. They are going to go under a little bit more high disinfection because of the esophagus and where that probe goes. The transvaginal and the transrectal transducers are inserted into places that are kind of dirty anyway. The vagina has tons of bacteria, the rectum has tons of bacteria. So it's not like we are super concerned about introducing normal bacteria back into the system, so we don't necessarily need a sterile transducer, and we know that we can't really sterilize our transducers anyway because of the chemicals or because of the heat that would be needed to do that. So how we clean our transvaginal or our transrectal transducers is usually in-house in the department. We'll first wipe them down with alcohol wipes, and then we wipe them down again with kind of like a bio wipe. It gets rid of some of the biological material. And then lastly, you are going to use a chemical liquid that will highly disinfect the transducer, and that's called glutaraldehyde, or Sidex is the one that you probably might hear when you're out and about. Or the big one now that most labs are using is called a Trophon unit that uses aerosolized hydrogen peroxide to warm it up, and it gets kind of sprayed, misted over this whole thing, and it works fantastic. It's a really nice tool to disinfect our transducers. So again, those endocavity probes are just taken a step further than our transabdominal probes or transthorax probes that we use. Another thing that we didn't talk about is a newer innovation that is being integrated into ultrasound machines. When you buy an ultrasound machine from like Philips or from GE, they have a very basic package. You can ultrasound with it, and you can maybe measure a couple things. And then if you want to do more specialized things with your ultrasound machine, then you buy these packages that get added on, that get downloaded into the ultrasound's computer drive. So not all machines can do, oh, I take that back. All machines can do 3D, but you can only really do it if you've downloaded that package. All machines can do cardiac imaging, but you can only do all the images or all the measurements for it if you have that package. So this fusion hybrid imaging, all machines should be capable of doing it, but will only be capable of actually doing it if you bought the fusion or hybrid package that goes along with it. Anyway, long story to get around to what is fusion hybrid imaging. So fusion hybrid imaging allows you as a sonographer to import a CT or an MRI. And so you bring that into the computer on the ultrasound system, and you bring it up, and then you attach sensors or this tracking system, and you locate on the CT where you are on the body with the ultrasound transducer, and the machine then can follow your hand where you move it and track where you are within the CT. And this is super helpful because there are lesions that we can't see very well by ultrasound. Because remember, we have to have different impedances. We have to have that change in that an echo needs to be created to see these lesions. And if it's the same material basically, or the same impedance, then we're not going to get those echoes returned. So sometimes CT and MR can see lesions much better than ultrasound can, but ultrasound is a much safer and easier way to perform biopsies. So we use this fusion hybrid imaging to track where we are in the patient and the imported CT or MRI, and then that just helps us to kind of guide to where the lesion is. So I have a video here from GE that we are going to take a look at, kind of shows their version of this fusion hybrid imaging. Try that again.
The Fusion tool within volume navigation gives you the remarkable ability to merge real-time ultrasound with a previously acquired CT, CT PET, MR, or ultrasound dataset. Start by loading a previously acquired dataset directly from a hard drive, USB memory stick, or CD attached to the system. Or you can simply load it via DICOM query retrieve. Then position the sensor unit so the anatomy of interest is within the electromagnetic field. The sensors are attached to the transducer. Next, register the ultrasound data to the previously acquired dataset by simply holding the transducer parallel to the slices that were acquired, then pushing the lock plane key. Now, mark a common point between the two images. Start by marking a point on the live scan. Then use the transducer to scan through the previously acquired dataset and mark the corresponding point. With a fusion setup complete,
so I'm just going to pause for a second here. What they ended up doing was finding the portal vein, the right portal vein, put a marker on it, and then they went to the CT and found the right portal vein in that image. So now the tracking system will be able to tell when the transducer moves down 2 centimeters, it'll bring the CT pictures down 2 centimeters. So kind of a really neat tool. We're going to probably stop here with the video. If you want to watch the whole thing, I did include the link to this video in your notes. Another type of innovation that has helped more on the vascular side of things is something called intravascular imaging, or IVUS. And what this does is uses a very, very tiny probe. Remember, we can get imaging or B-mode pictures with one crystal. So we really only need one crystal to get a picture, but there's a handful of crystals on the end of this very, very tiny probe. And it is inserted in through the femoral vein or through the femoral artery. And it can be driven through these vessels and gets a 360-degree view of the vessel from the inside. So that's actually kind of cool. It can help to evaluate stenosis, as we're seeing here. We have the vessel wall. We can see the vessel wall gets a little bit smaller here. That is because there is plaque buildup. And then they can go in and measure and get a super accurate look at that. So IVUS is typically used to evaluate cardiac arteries right now. I believe that's where it's been used most. It doesn't use any sort of x-ray like catheterization does, and that's typically how they've been looking at heart vessels. They put a dye in and then they use x-ray to see how that dye fills in the heart vessels. Well, now they can go in with ultrasound, no x-ray, no dye, and they can go in and actually see and measure the extent of stenosis within the vessels. So kind of another cool tool that is out there. Another tool on our machine that we did not talk about is something called tissue Doppler. Tissue Doppler is typically going to be used for cardiac imaging. And what tissue Doppler is it uses the color mode or color Doppler on the ultrasound machine to detect motion of the heart walls. And so typically when we use our color, just looking at blood flowing through vessels or blood flowing through the valves of the heart, what we are doing is really looking at the higher velocities that are going along with the movement of the blood. And so we use a low pass filter to get rid of kind of all those low velocities that we don't want that information from. That's why we don't get color that goes onto the walls. We don't get color that goes into the vessel walls. And all we see then is the color moving through the vessel. Well, tissue Doppler kind of goes the opposite direction. It uses a high pass filter, which filters out all of the high velocities and then only displays those really, really, really low velocities like those found in the motion of the heart. So you put this tissue Doppler on, it highlights the vessel walls and it will show, or the heart walls, and it'll show you how they are moving. So the color really only appears along the walls. I have another video here that shows us about that, and I think this is actually pretty cool technology. Not being a cardiac sonographer myself, I have not seen this used in real life, and I'm not 100% sure of the application of it, but it definitely looks cool. So we'll watch a part of this here just to kind of show you. So you can see the heart.
Left ventricular tissue Doppler measurement.
And you can see there's blood
One of the
flowing
most
through here,
important
but the low pass
evaluation
filter is
for
on.
diastolic
We're seeing
dysfunction
high pass
of
filter
the
is
left
on.
ventricle
We're
is
not seeing the
tissue
blood flow.
Doppler.
We're just seeing the low velocity.
In tissue Doppler, first we get apical four-chamber, and then we select tissue Doppler.
Process. So we're just seeing the low velocities that are being generated by the contraction of the muscle. So again, if you want to watch the entire video, you can click on the link provided in your notes. Measuring ultrasound images. So this is a pretty basic concept, but one of the mock tests that I had looked through had some questions on it, so I wanted to make sure that we included it in our mishmash unit here. So measuring on the display is actually a feature of the display itself. We know that our displays are capable of displaying the grayscale images due to however many bits are assigned, yada yada yada, but it also is able to display some red, blue, and green. There's actually more pixels doing some extra stuff in there. And then on top of that, we have computer components that now can recognize how deep we are, where we are at, so we can measure the echoes that we're getting back. So with that, we place calipers around on the B mode image. We might place them in the M mode image, or we'll place them on our spectral tracing. And when we measure, those calipers come up and they tell us different information. So for example, in B mode, we can put calipers on to measure how deep a structure is into the body. We can measure the length, width, and height of any structures. We can measure the circumference of a structure, so that's going around the outside, maybe the outside of a vessel, outside of the fetal head. We can measure the area of the structure and the volume of the structure as well. What I've included on this slide behind each of these is the expected unit that those will be measured in. So remember, the biggest part on this is any length or circumference is centimeter. Area is always measured in a unit squared, so centimeter squared typically for ours, or if you think about your house, your square foot is the area of your house. And then volumes are cubed measurements, typically done in a couple planes, so we can get the three planes all volumed together. On our spectral tracing, we can place calipers to measure the velocities. We can measure resistive index, and we can also measure acceleration time. We're actually going to talk a little bit more about a couple of those terms in a few slides here. When we're looking at the M mode, and I should go back to this centimeters or meters per second. Remember, these are times over, a distance over a time, which gives us part of the velocity piece of it. Resistive index is a unitless number. Again, we'll talk about it in a second. And then acceleration time is also a unit of time. When we're looking at the M mode image, we can place calipers on that to measure distance of motion. Again, any distance is going to be in centimeters. We can also measure the length, width, or height of structures displayed in our M mode, and then quite often we use it to measure beats per minute of the heart rate. When we're measuring our structures on the ultrasound system, length is typically going to be in the longest axis of the organ. So we talk about being in a longitudinal sagittal plane. That sagittal plane is long to the human body, but it might not be long to the organ. So length again is the longest axis of the organ. Height then is going to be perpendicular to that, measuring from the anterior to the posterior aspect. So sometimes height is referred to as the AP measurement. Width then is going to be on the shortest axis of the organ, typically 90 degrees from the long axis. And then on ultrasound, standard practice is to measure horizontally across the screen. We can also do AP in the horizontal axis, again 90 degrees to it. Another feature on our ultrasound machine is called the cine. The cine is very helpful, especially when you have a patient that's moving or you need to capture some live imaging of what you're seeing. So for general ultrasound, quite often what you'll probably notice is you'll be scanning and then you'll see something and you'll freeze, and then you can cine back, go back a couple frames and grab that picture of what you just saw. So the cine is the machine kind of temporarily saving like 120 frames. So you can scroll back a couple frames and find what you were looking for. As a new sonographer, I do encourage you to not rely on your cine. So often I see students like, oh, I think it was back there, and they just scroll and scroll and scroll and scroll. If you're scrolling that much, just get a new picture. As a sonographer who's been doing this for a while now, I actually really rarely use my cine clip unless it's a motion thing where maybe I saw a gallstone for a second and then it was gone. Oh, I'll scroll back to where I saw it for that second. So general uses it more as I saw something, I gotta get back to it. We also, in general sonography, will use the cine clip to record ourselves, maybe sweeping through an area of pathology, so we can then send that kind of real time image video to the radiologist so they can review the pathology that we're seeing in real time as well. Echo, on the other side of things though, actually almost uses cine exclusively. So instead of taking still images, echocardiographers quite often take clip after clip after clip, and it's only 2 or 3 seconds for each one, but it's easier to show motion to the cardiologist through clips than it is through a still picture. You just can't through a still picture. So quite often cine clips are used in 2 to 3 second bursts to show wall motion, to show how blood is flowing through a valve, to show how the heart's contracting, that kind of stuff. So it's not uncommon for echocardiographers to only use clips, or general is going to use it more to display pathology to the radiologist. We're getting close here, so to the end of our mishmash. Waveform anatomy. I debated on putting this into our Doppler unit, and I think I talked maybe a little bit about some of these topics, but I didn't want to stray too far from what the book was teaching you, so I'm just kind of throwing it in here now. This is a very, very basic list of things that you'll see on your waveform, and it might just help you if you hear it in a question just to be able to kind of relate back to what they're talking about. Most of these are going to be involved more on the vascular side of things, the vascular exams. But we do have 3 different types of waveforms that we typically see within the body. Remember, we talked about pulsatile, phasic, and steady flow. This is another way to describe flow that we're seeing. So we have triphasic. Triphasic means that we have an above, below, and above portion to the waveform. So this is a pulsatile, but it's triphasic because it has those 3 portions, above, below, above. Biphasic then, you can hopefully see where this is going. We have an above and below portion. This actually is also pulsatile, typically found in arteries. But again, biphasic, above, below, just those 2 components. Lastly, then we have monophasic, and monophasic stays all above the baseline, or all below the baseline technically too. But this one is also pulsatile. So remember, pulsatile was anything that reacted to heart contractions that had varying velocities. These all have varying velocities. They're reacting to the heart. It all depends on where these blood cells, where are they going? Kind of depends on what your waveform will look like. So triphasic, above, below, above. Biphasic, above, below. Monophasic, everything stays above. When we look at our waveform then, a couple things that the two biggest things that we measure are going to be peak systolic velocity. That's going to be the fastest velocity, typically right at the height of systole. And then we're going to have our end diastolic velocity, and that is going to be at the end of the diastolic period, right before systole starts again. So we have our PSV and our EDV. When we measure PSV, subtract EDV from it, and then divide it all by the PSV, we are calculating the resistive index. The resistive index is a calculation that tells us how resistive is the vascular bed of where this blood is going. Now, when we have low resistive waveforms, they're typically going to be monophasic, so everything's above the baseline. And these types of waveforms are usually going to organs that need blood, like your brain, like your liver, like your heart, like your kidneys. Those need blood constantly to function. So they're going to have monophasic waveforms when they're operating normally. On the other side of that, limbs, your intestines, when you're not eating, they don't need nearly as much blood. So we'll see waveforms going to those areas to be more biphasic or triphasic. So low resistive waveforms are typically monophasic and will get a lower resistive index calculation. High resistive waveforms are going to have a resistive index of like a 0.9 or 1. If you think about it, you have your PSV, and technically your end diastolic is 0. So you have PSV minus 0 divided by PSV equals 1. And so that's why our high resistive indices are typically in that 0.91 range. Another thing we can calculate from the EDV to PSV is looking at the time that it takes for this acceleration to happen. So we call this the acceleration time. It is a measurement of time. Usually we want it below 0.08 seconds. Longer acceleration times tell us that there's probably some sort of abnormality going on here. Typically, we want a nice, quick upstroke during systole. Sweep speed is another control on your machine that will change how quickly the waveforms are displayed on your monitor. So this video that I have here is kind of a training video for a system unit called MindRay, and it actually goes over a lot of that knobology that we talked about, the gain, how to move the sample volume, angle correct, all of that. So it actually might be a nice review video for those of you that just kind of want to review knobology and what everything does. But I'm going to start this video where they talk about sweep speed, and you'll get to see how changing the sweep speed changes how quickly waveforms are displayed on the monitor. Let's try that again, one more time here. So we're about 9 minutes into.
And sweep speed too is important.
So then that's down on that same row. When we came down a row, we saw the duplex on and off, and the sweep speed is over there in that corner.
Okay.
And so just like you've made adjustments before, if you hit that cursor, you can change that with the navigation key,
Okay.
also with the set key, or
Nice.
on the
Or-
soft keys right
right.
up there. And that's, user preference.
So I'm just going to pause for a second. They are increasing the sweep speed. So you'll see that the waveforms kind of come across slowly and you don't get nearly as many displayed. and then you get a few more displayed, and then when you increase your sweep speed, you can get a whole bunch of waveforms displayed.
Preference, if you're a physician, you know, you'll like it a certain way. If you're a sonographer, if you're a
Well,
nurse.
depending on what you're looking at.
Exactly.
Right? Yeah.
Yep, all sorts of changes you can make to adjust it the way that you want to have it.
And you could adjust it when you get there as the clinical applications. You could adjust the sweep speed depending on the exam. So if I'm doing a renal artery study and I wanted a specific speed versus a carotid, you could set it and it would
Right.
save it for you. Yeah,
Exactly. So these are all things.
So again, sweep speed just shows us how many waveforms we can kind of jam into that time. It does change the x-axis of our baseline. Remember, the x-axis in our spectral tracing is time. The y-axis is velocity. So we change the unit of time that we're displaying, therefore displaying more or less waveforms underneath. All right, last subject that we need to talk about. We're so close to done, you guys. Gold standard test. This is a little bit newer to the physics test, and if you take your vascular boards, you will need to know this in much more detail than you need to know it for your physics test. But for the gold standard test, I just kind of want to introduce you to it and introduce you into some of the key terms and how those terms are defined. I think that'll be enough for what you need for your boards. When you go to your vascular test, you actually have to know how to calculate all these out, but I don't think you need it for your physics test, so I don't want to waste our time on it right now. But gold standard test, what is it? So gold standard test is basically the way that we define tests that are really, really awesome at detecting disease. So my example here, I use CT and appendicitis. Ultrasound can look for appendicitis, especially on kids, maybe some thinner adults. We can see it. We can kind of see what's around and maybe infer that there might be appendicitis, but we're just not 100% accurate at it. Compare that to CT, which is actually really good at seeing the appendix and saying yes or no, that's appendicitis. And so when we look at gold standard tests, we are looking for what tests have 100% sensitivity and 100% specificity. Oh, it's getting late in this lecture. All right, we're going to move on. And the idea of 100% of either of those is kind of an idealistic idea, because it's not always going to be the case. So there are some tests that just, or some diseases that just don't have gold standard tests for them, but there's a lot that we've come to accept that we do believe to be gold standard tests. An example for general ultrasound, fetal surveys. Doing a fetal ultrasound is the gold standard for detecting fetal anomalies compared to doing an x-ray, compared to just doing blood work. So there are multiple ways of looking at a disease or looking at pathology, looking at the fetus. Some are just better than others. So the best one is the gold standard test. Now, some other terms that go along with this, these are all statistical terms, and again, you're going to need to know how to calculate these if you take your vascular boards, but I just want to go over these topics because there's a good chance at least one question will show up on your boards because of them. If you think it'll help you to watch a video that goes into how to calculate these, there are tons of videos on YouTube. Again, I didn't want to put that onto this lecture and have you feel like you needed to know how to calculate things quite yet, because I don't think you need to know it for your boards. That being said though, sensitivity. So we talked about gold standard tests having 100% sensitivity. Well, that means that it has a 100% or the ability to correctly identify patients that have a disease. It's the true positive rate. So if we have 1,000 patients, and let's say we are testing for gallstones. 1,000 patients, and let's say 50 of them have known gallstones. The sensitivity of an ultrasound of the abdomen then would say how many of those 50 people can we accurately detect their gallstones on? What is the sensitivity that we actually pick up disease that is there? Now, specificity refers to how many people will we correctly identify that don't have the disease? So again, back to those 1,000 people, will we be able to tell in the other 950 that they don't have gallstones? So again, sensitivity tells us, can we accurately identify all 50 that have gallstones? Specificity tells us, can we correctly identify the other 950 as not having gallstones? So sensitivity is true positive rate. Specificity is true negative rate. So those are two things. The closer those are to 100%, then the closer that test is to the gold standard. Now, a couple other terms that you might hear in regards to gold standard tests or to the realm of how accurate tests are positive predictive value and negative predictive value. So the positive predictive value is what is the probability that subjects with a positive screening test truly have the disease, where the negative predictive value is what is the probability that subjects with a negative screening test truly don't have the disease. Now, an example that I'll use for this goes back to OB, and an OB test for Down syndrome is called the nuchal translucency test. And you take some blood work from mom, you take some pictures of the fetus, and you send these off to a lab and they analyze it all. But this is a screening tool. The screening tool tells the provider this patient has 50% chance of having a baby with Down syndrome. This patient has a 2% chance of having a baby with Down syndrome. So the positive predictive value of that test is how accurate is that 50%? How accurate is that 2%? How accurate is it at saying that is a positive test? Versus the negative part of it, how accurate is it that screening came back negative? Like that 2% one is mostly a negative. Is that super accurate? Another way you can think about it, we're dealing with coronavirus right now. The tests that are out there are kind of questionable in their positive and negative predictive values. When a person gets that test done, their test comes back positive. How positive are we? How that it is truly positive versus a false positive? Compare that then to you get your coronavirus test back and it's negative. Is that a true negative or a false negative? And that would be its negative predictive value. So positive and negative predictive values have to do with screening tools and determining how accurate a test is in its screening. Lastly, then we have the term prevalence. And prevalence tells us the proportion of individuals of the population having a disease compared to the rest of the population. So again, let's use coronavirus as an example. You probably have heard, we have cases, I'm just throwing a number out there because I have no idea what they are right now. We have cases in Minnesota, we have 10 cases per every 1,000. So that's 10 people with a positive disease or characteristic compared to a population set for the 1,000. So that tells us how prevalent the disease is in the population. And that, my friends, is the end of physics. So again, just to recap, you will not have any official testing on this chapter. There will be questions in your mock and on your final in regards to some of these topics, but I do want to make sure that you have at least been introduced to them in case they do show up on your SPI as well. Thank you so much for a fantastic semester. I hope you guys learned a lot. I would love to hear how you do on your boards. Please ask me if you have any questions about your boards, signing up for them, getting ready for them, what you can study, just any questions. I'm here for you now. I'm here for you in the future. If you decide to take your test later, please let me know if I can help you anyway. And again, please let me know if you take it and pass it or don't pass it, which hopefully, fingers crossed, is not going to be an issue. But if you just want to review things or kind of talk it through, let me know if I can help you again in any sort of way.